So it's a pleasure to introduce our chair for this afternoon's session. Dr. Patricia Pierce is an assistant professor in the Department of Psychiatry, where she's very active in providing psychotherapy training and supervision. She believes that her practice of psychiatry and psychotherapy is firmly grounded in her first 4 years as a physician, where she worked in a rural practice and emergency medicine, and recognized how essential it is to view the individual's emotional problems in the context of social relationships. With a special clinical area of interest in women's reproductive mental health, and as I mentioned, in teaching and supervision, she employs what she describes as an eclectic psychotherapy approach informed by both interpersonal and cognitive behavioral therapy. So it's now my pleasure to turn things over to her.
Thank you, Heather, and it's a real honor to be part of this panel this afternoon. Some of the words that, some of the adjectives that have come up as I was watching the first half of this morning's sessions are exciting, enriching, innovative, evolving, inspiring, current, and state-of-the-art. And I hope that what we get from this can be further continued in terms of training and supervision. And I noticed that David Pilon was sitting, and he tells me he takes notes about everything, but I was dreaming really. It was a to-do list, and he was sort of prioritizing how he would arrange for supervision and further training, but no pressure there. Gives me great pleasure to introduce Anne Mahoney, who actually has connections with Halifax that I had no idea about, although I had heard her name before. She is a psychologist, trained here but now working in Calgary, and the kind of things that really warmed my heart when I read her brief bio is that she deals with shame-based disorders, integrates mindfulness awareness, and the part that really clinched it for me is she uses equine facilitated therapy in her clinical work, and that's something that I had done with children with disabilities earlier on. So I just think she must be a really good, solid, well-grounded person. It gives me great pleasure to introduce Anne Mahoney, who also has teaching and supervision, I guess, work here in Nova Scotia, even though she is primarily in Calgary.
Thank you very much, Patty, for that nice introduction. My life is not quite as chaotic as that just sounded, just so you know. It's a great pleasure for me to be here, and I'm not going to actually talk about any of those things. I very much enjoyed this morning's talk on mindfulness. It was quite delightful to hear other people talk about that. And I couldn't bring my horses. They just really refused to get on the plane, so I'm going to talk about group therapy, which is actually what I was asked to talk about. I was here quite some time ago, maybe 10 years ago, to give a talk on group therapy. And at that time, they gave me 2 days. Okay? So I'm not going to try to squeeze that talk into 45 minutes. I'm going to focus on a very particular phenomena in the development of group, which I think is essential in determining whether or not group therapy is efficient and effective. So when is a group not a group? I just want to begin by saying a little bit about my perception of group as I get feedback from people who are not in the area of group therapy. And I think even in the 21st century, there's still a lot of ambivalence about the effectiveness of group. Is it a second-rate therapy? Is it just a place we put people when we don't know what else to do with them? How is it different from individual therapy? What's the point? What I will argue today, and I hope to be able to provide you with some things to think about in this regard, is that when that attitude is prevalent, there has been a failure to create a group, where what we have is a collection of individuals. And so today I want to walk us through the steps necessary to move from a collection of individuals into an actual group, right, that's functional. So I don't have any disclosures that I need to make. The learning objectives for today, I can't see my monitor, so I just have to do an adjustment. First of all, is to understand what group is and what it is not. To explore the role of what's called the therapeutic factors. These are phenomena that occur only in group therapy. They don't occur in individual therapy. They require, a collection of individuals for them to be activated. To understand the role of cohesion in group therapy, and to explore the relationship between process and structure in building cohesion. That's an ambitious agenda for 45 minutes, so let's just see how we do. So first of all, the most important question, I guess, is what is group therapy? And again, what I'm going to do today is speak about group therapy from an atheoretical perspective. So the comments I make apply to all kinds of group therapy: motivational therapy, mindfulness-based therapy, DBT, CBT, psychodynamic therapy. And what's important is to understand that we must attend to both the client-client interaction and the client-therapist interaction, and how those interactions are used to promote change. That sounds pretty straightforward, but there's often, in the living experience, it's very difficult for people to know how to facilitate movement and interaction in the group without the therapist or the leader being the center of attention. So we'll spend more time on that in a few minutes. Fundamentally, it's important to understand that no matter what kind of group you are running, group is a dynamic force. Group is larger than the sum of the members. It has an energy of its own, and if we fail to be conscious of that group level phenomena, right, we fail to use the uniqueness of group to promote change. And we run the risk of being back in the place where we're doing individual work with an audience. So when we want to look at how we're going to move a collection of individuals into a therapy group, although it could be a working group, a management group, a government, a board of directors, it could be any kind of functional group. How we move a collection of individuals into a group depends on a number of factors. First of all, we want to be careful to understand what are the myths that we hold and that our patients or clients hold about group. We need to understand the therapeutic factors and how they play out at different stages of group. You need, and I need, to know our biases about group, the beliefs that we carry and influence us as group leaders. We need to let go of any preconceived ideas we have of how group leaders are supposed to behave. And we need to know the consequence of not building safety and how to build safety in a group. And also the process of cultivating cohesion. So on this slide, there's just a list of myths about group. You can Google group myths and get a multitude of lists, but basically they all say about the same thing. So it is common and has historically been common for people to think that group is a second-rate therapy, that group makes people talk about things they don't want to discuss. It's about talking with others, in quotation marks, sick people, and how that's just going to make things worse. I'm not going to feel better if I do that. Some people are scared that they'll lose control in group, and other people are afraid that they'll be judged. I would like you to take a moment and think about which one of these myths, right, that resonates for you. Is there any part of you that has some belief in one of these myths? And if there is, it's not, don't judge that. Just know that you have it, all right? Because our preconceived ideas will really influence our ability to move a collection of individuals into a group. You also need to think about how do you address these issues, all right, with the clients or the patients. So I'm just going to give you a minute to personalize that for yourselves. One of the things about mindfulness that is so incredibly helpful in everything in life, including being a group therapist, is that it allows us to hold a space in our mind where we can just be aware of what's arising inside ourselves and in the group room. That's what we would call pure awareness, all right? So there's no narrative attached to that awareness. It's just a knowing. And it's in that space that it's easiest to do group work. It's in that space that it's probably easiest to do everything in life, but since I'm talking about groups, we'll frame it in that way. So it's not that it's a problem, all right, to have certain beliefs about groups or perhaps to have some misinformation about group. It's only a problem if you act on it in an unconscious way, obviously. Okay? When I first began group, one of the things that I thought about group was that it would be impossible to pay attention to enough things, right? That there would be that you would just keep. I couldn't possibly pay attention to 8 people doing 8 different things all at the same time. And as long as I believed that, I couldn't do it, right? So that's why it's important to understand any of the myths that we might be attached to in one way or another. So we're going to leave that for the moment and move on to therapeutic factors. There are probably 3 or 4 different lists of therapeutic factors. The one that I have put up today is the one that was empirically determined by Yalom many years ago. He is a grandfather in interpersonal group therapy, and his version of the therapeutic factors still, all right, is very popular, and it captures the points that need to be made. So what these are phenomena that occur in groups that promote change. But they only promote change if the facilitator knows how to make use of them. Right? So in other words, they need to be an understood experience. So one of the ways that failure to understand the therapeutic factors is problematic is failure to understand them means we stay with a collection of individuals. We don't transition, all right, into a group. The most important therapeutic factors for us to consider today are the installation of hope, interpersonal learning, the cohesion, and depending on the type of the group running, what's called corrective recapitulation of family. Installation of hope, universality are 2 factors that are influential at the beginning of any group. Doesn't matter what kind of group. They say that change is possible and that you're not alone. Other people are stuck. Other people are confused. Other people have the same kind of dilemma. That's the beginning of helping the group become a group. It's the beginning of connecting this collection of individuals, all right, into a solid group. It begins to give a sense of we-ness. The complete process of that is generally referred to as cohesion, and we'll go through that in great detail, but it is also listed as one of the therapeutic factors. Interpersonal learning is the process of being able to give and receive feedback from other group members, right, and tolerate the emotional discomfort around that process. It builds self-confidence, competence, it gives people courage, and it makes the tie between the group members stronger. It doesn't matter what kind of group you're running, the reality is that we all bring ourselves to that process. Right? If I'm running an educational group, or an open-ended psychodynamic group, I'm still bringing myself to the group, and the group members are bringing themselves to the group. So they will inevitably behave the way they know how to behave. They can't do anything else, right? So the habit patterns that they have, the things they've learned, whether they are constructive or not constructive, growing up, they will bring to group. And how they show them in group is going to be shaped by the purpose of the group. I'm going to argue, and those of you who have worked with me know that I argue this a lot, that there's huge value in understanding what those habit patterns are. Not because you're necessarily going to work with them directly in group, but when you know what they are, it will be easier for you to help the group cohese and to form, right, a functional group. It moves you farther away from the collection of individuals. I want to just go back to the issue of bias for the moment. When we talked about myths, we could also refer to this as bias. But I've put up a slide here that will talk a bit more about bias. And I would like you to take a few minutes and just try to answer these questions for yourselves. You don't have to share it with anybody. So think about how much do you know about group. Some of you know a great deal about group, and some of you may not know much at all, if anything. There's no right or wrong answer here. Just be honest with yourself. And what kind of group do you think is the best, the most efficient, the most effective for patients? Are they the short-term or the long-term groups? And what is short-term and what is long-term? Are they open-ended groups or closed groups? Do they focus on content or do they focus on process? Again, all of these things make a difference in terms of how you're going to see the world. Right? So to go back to some of the talks from this morning, all right, it's not what happens externally, it's our perception of what happens that matters. And I want you to think about whether you prefer individual therapy or group therapy, and why. So for all the therapists in the room, just think about that. What's your preference and why? Next question. What's uncomfortable about leading a group? And finally, what's fun and interesting about leading a group? When we don't know the answers to these questions, right, we are at risk of not being able to facilitate what's going on in the room. If we take too much bias into the room, we won't see what's happening. Right? Our filters will be too strong, and we'll see what we expect to see based on our bias. It's fine, and it's true when we say that if we are just mindful, this will all be fine. But mindfulness is not as easy as it sounds when we describe it to people, right? Our minds are incredibly fast, and we can jump from thought to thought and back to being mindful before we even know we'd left the mindfulness in the first place. So sometimes it's really helpful to have sort of some cognitive structure, all right, that will cue you into where your mind is likely to go. When I started group many, many years ago, everything about it was uncomfortable. My biggest fear is I'd be too anxious to talk. I thought short-term closed groups were the best because I figured they'd be over fast and I didn't have new faces every week. Okay? And the fun part was getting through the session and out the door. Okay? It really helped that I knew that. It really helped that I could just learn to set that aside and be present. The next thing that we need to understand in order to transcend a collection of individuals and become a group is we need to understand the kind of leadership style that we think we're supposed to have, or that we want to have, or that we're supposed to have, and get past some of those misconceptions. For me, the biggest misconception is that that being a group therapist is the same thing as being an individual therapist. You just have a group of people, right? I'm just going to talk to each person, and they're going to talk to me, and that will guarantee that you remain in a room with a collection of individuals. Okay? You will never have a group if that's what happens. And groups will push to have that happen. It's not just us as group leaders that might have bias. Lots of clients or patients that are in group think that it's a second-rate therapy, think that only the therapist or the group leader can be helpful. How could these other people, right, who also have problems possibly help me? And so the group members will push to be the special group member, right? They want all of your attention. And to the extent that you facilitate that, right, is the extent to which your group will stay stuck, and it will be a collection of individuals. And the efficacy of the process will be significantly diminished. As Scott said earlier today, we don't like to be told what to do. So having an attitude of, if the members just did what I told them to do, there'd be no problem, isn't going to work, right? Any better in group therapy than in motivational interviewing. The ability to move a collection of individuals into a group requires that we can hold an open space in our mind and simply respond to what's happening in the room. Usually in a constructive way, as opposed to a destructive way. But if we go in with an agenda, we will lose the ability to activate the unique therapeutic factors of group. And I'm serious about this. Even if you are running, right, a scripted psychoeducational group where there's a certain amount of content that you have to go through, the art in creating a group is to be able to use that content, teach that content in the context of the here and now. If you let your group members stay too far out of the here and now, you will continue to have a collection of individuals, and you will be doing individual therapy with an audience. There's no way around that, except to be able to let them interact with each other around the content, right, or the structure of your group in the here and now. And that's what's going to pull them into being a functional group. The third misconception about leadership style is this is a anxiety management group. That's what a blank group, just put in the name of a group there. And so therefore, why would I need to know anything about the members' family of origin or their interpersonal patterns? Well, as I alluded to earlier, of course you do. The way I get angry and the triggers that make me angry, all right, can arise in any context in my life. If I get angry when I feel like I'm not being listened to, it hardly matters what kind of group I'm in. I can pretty much guarantee you I'm going to feel like I'm not being listened to at some point, right? And I'm going to activate. So if you have some sense, I'm not saying you have to memorize 4 pages of notes on everybody that goes into your group, but if you have some broad strokes of understanding around what their habit patterns are, your clients' habit patterns are, then you have a much better sense of how to pull people together. We'll talk more about how to do that in a few minutes. And my last rather sarcastic comment here, I have to get them to stop talking so I can get through the material for this week, is just a reminder of how easy it is for us to get caught up in the content, all right, in the task at hand. Whenever I'm caught up in the task at hand, I am not present. I guarantee it, and I guarantee that that would be true for you as well. Okay? So if I have to be doing something, I am not here to see what's happening. I'm not open and responsive to the needs of the patients, or the clients. Okay, here's one of the big things that we need to understand, and that is the role of cohesion in transforming a group of individuals, or a collection of individuals, into a group. So first of all, what is cohesion? The literature would argue that it's simply one of the fundamental building blocks for group therapy. It's the base on which all the therapeutic factors are grounded, and it serves to sustain the group during difficult times. Without cohesion, it is not safe to talk about the secrets, the shame, the fears. And so group, to use a Canadian euphemism, just stays nice. Okay? Everybody's nice, everybody's pleasant, everybody says all the right things, and nobody gets any work done. So when we build cohesion, we build the mechanism by which, all right, a sense of we-ness or the sense of groupness develops. This is not a small task, all right? I sometimes, when I talk about this, it sounds like, oh, this is pretty straightforward and pretty easy, but building cohesion is the most important thing in developing a group. And it can be extremely difficult. We don't always have a collection of individuals who actually want to be in group or are really ready to make any changes, right? Nor do we have people who necessarily have huge insight into their own defenses and resistances. So there's lots of obstacles to building cohesion. If we can get through these obstacles, what happens is we have helped the group members find a way to belong. And we primarily do this by encouraging the group members to talk to each other about ways that they're similar. Now, what does this mean for me, you, as the group leader? I'll just go back here. I don't want you to be distracted by that. What it means is I have to get out of center stage. All right? I simply become the person as the group leader that directs the traffic. I don't want group members talking to me a lot. I want them talking to each other. And so I must learn to speak what I call group speak. I have to help the group members by modeling, all right, how to talk to each other. So when group member Mary says something and I notice that group member John is nodding his head, I would say something like, John, could you tell Mary, or could you let the group know what it was about Mary's comment that resonated for you? Okay, so that sounds really straightforward. That doesn't, take a lot of, right? Anything to say that, except if you've been a group therapist for anything more than 3 days, we don't think that way, all right? It's very, very difficult to move our language into group speak. This is another problem, right? This is another way in which we fail to move a collection of individuals into a group, is we're still talking as if we're having an individual session or an individual conversation with one person. And I always know when I've made that mistake because people look at me when they answer and I go, oh, I'm sorry. I know I asked the question, but really tell the group. Okay? It's a really important, very critical thing to do. And the reason it's important is because to build safety in a group, the members have to be safe with each other. And with people who have persistent mental illness, right? This is a very, very important point. Most people who have persistent mental illness and are still in the system have gotten to the point where they more or less trust the therapist, but they don't trust anybody else. So it's not me they're worried about, it's all those other people, all those other, in quotation marks, sick people, right, that they can't trust until you show them how to do that. When we've been successful, in building cohesion, what we have are some standard kind of behaviors in group that tell us that we have been successful. And these are taken from a book by K. Roy McKenzie, who was a well-known group therapist. and developed the model for time-limited group procedures, which is still commonly used. So first of all, people come regularly and they're on time for group. Many of you will work in the context where people don't have a choice around that, all right? If they miss group or if they come more than 5 minutes late, they're going to be kicked out of the program after so many occurrences, right? So that isn't always a good marker. A few premature terminations, people who leave before they finish doing the work they need to do. So, in other words, dropouts. This is a very useful thing in an open-ended group where people have freedom to come and go, right? But again, if you're in a program where certain behaviors are not allowed and after so many occurrences of those behaviors they have to leave the program, this is not useful. People who seem to be happy to be in the group and they want to remain. This is probably one of your best ways to know that you've been successful with what I call round 1 of cohesion. And when people are interested in each other, when they remember what other group members said and they ask about them from week to week, that's a very good sign. Activity level is a good indicator, right? It's not true that the higher the activity, the better, but the sincerity of the more sincere the activity is, the better. We can also measure or just monitor self-disclosure and trust. And really, I recommend you listen for the word we. When the group starts to talk about we, you know that you've gotten through round 2 of building cohesion. That's the point at which this group is no longer your group. It belongs to the members. And now we can get down to work. Right? Now the purpose of the group can start to unfold, right? And the potential for change is significantly magnified. And of course, if the level of defensiveness in tension is low, that's also a very good sign. Okay, so what's the role of the therapist? What do you need to do to help cultivate all of this? Well, I said already, right, that we need to speak the language of group. We need to promote disclosure. We need to stop being afraid that people are too fragile. We need to understand that there is an inherent integrity in the group and in the individual, right, to do this work. All too often, in my experience, we as group therapists are way too nice, way too careful. We pussyfoot around what needs to be asked or what needs to be said, okay? And we fail to be direct and respectful. So what I mean by that is just say, make a reflection. You're really angry. Are you able to tell the group what that's about? Do you realize the impact that your comment had on John? Are you willing to hear John's feedback? I notice you're looking at the floor. I'm wondering if your shame got activated. That's just truth. You may be wrong, but that's okay. Right? But if you aren't clear, and if you're not present, and if you don't have empathy, you can't keep the group, you can't make the group cohese, you can't help it to cohese, and you can't keep it there. And you're not building safety. So promoting disclosure is not about just getting everybody in the room to say something about themselves. When I first started, that's what I thought it was. I thought, okay, once I've got everybody in the group that says something more than hello, my name is, all right, then I'm doing good. Well, 30 plus years later, right, I understand the importance of being really direct and really honest and empathic, right, and just cutting to the emotional level. If you're comfortable doing that, the group will be fine. If you're uncomfortable doing it, don't do it, because you'll make the group nervous. If you don't feel safe in the room and you convey that to the members, right, the group can't cohese. I'm sorry, I'm distracted by this little yellow piece of paper over there. I'm not quite sure whether I'm supposed to be paying attention to my 5-minute warning yet or not.
Oh,
No.
sorry, I
Okay.
was fumbling. I'm sorry, distracted.
Phew, okay. So, and then you have to encourage people to speak to each other. This is the directing traffic, right? And it sounds very artificial, I guess, when I describe it. And I know it felt very awkward many years ago when I started to work. But it really is the ability, all right, to say, you know, Mary, can you tell John what that head nod was about? Or Elizabeth, you look like you're struggling with something right now. Are you able to share with the group what that's about? Okay. So I'm not asking people to speak to me, and when they try to speak to me, I'm going to discourage them. Elizabeth makes some disclosure, and I might say to the group, I wonder who else resonates with that. Or, Jane, that sounds similar to something you said last week. Can you and Elizabeth explore it a bit further? Right? So that if you know the histories, you'll understand a bit better about which members you might want to connect with other members. But that's all you're doing, is connecting members. If you become the central figure, something is going to go wrong. Right? You're going to end up with a collection of individuals. And this is a collection of individuals, a delightful collection of individuals. There's nothing wrong with that, okay? But if you're trying to run a therapy group, you don't want a collection of individuals. Now, the next thing is really important because I'm trying to talk about all kinds of groups at the same time. So the way we make sense out of this and the way it becomes constructive is we have to understand what the purpose of the group is, right? So whether it's a DBT group, it's an anger management group, it's an open-ended psychodynamic group, every group has a purpose. I do not mean the theme for a particular session. I mean the overriding purpose in the life of the group. You'd be amazed at the number of people who run groups and they don't know the answer to that question. Right? So I ask every student I work with, this is the first question I ask: what is the purpose of your group? And something like 50% of the time they don't know. Okay? So please pay attention to this. Write the question down. What is the purpose of your group? And you and your co-facilitator, your team, think about that. And when you know the answer to the purpose of your group, you always have a way to pull the group together. Because that's how you frame your questions to the group. If this is an anger management group, where people are learning different ways, right, of coping with their anger, and you're teaching things, you're giving, you're talking about different techniques. You might be talking about relaxation therapy and mindfulness. Right? And somebody seems really agitated in the room. What you would do is you'd ask them about their feelings in the room in relation to the material that you're teaching them. Right? So I would be quick to say, John, you seem very restless. Are you angry? Okay, what can the group tell you about what we've been learning that might help that anger settle down? What can the group practice with you to help that settle down? So rather than having the content dissociate it with the individual's lived experience, you're trying to make the content relevant to the lived experience in the present moment. That will build cohesion. And the last thing is to explore the process, that dirty word process. So, I think very quickly, I need to talk about, yes, what is process? So, process is a psychodynamic concept, and there are many elaborate and complex operational definitions for process. But in a very practical sense, process is simply how we interact with each other and why we do or say what we're doing and saying at the time we're doing it. It's that simple. It doesn't need to be any more complicated than that. And process always occurs in the here and now, so it's always in the present moment. So again, if we can take how people speak with each other. Jane, I noticed when you talked to Tom that you were very fidgety. What's happening inside your body right now that makes it difficult to relax? If that was the appropriate context for the group. Jane, I noticed when you talked to Tom, you were very fidgety. Who is it that Tom reminds you of that causes that agitation in your body, if that's the context of the group? That's all process is. And it's the level of process, it is at the level of process that we connect to people. I do not become close to the people who just blindly say the things I want to hear. I become close to the people who say the things I want to hear in a voice that sounds like it's real, like they believe it, like it's authentic. The authenticity, the empathy, right? The compassion is what I connect to. That's what brings me together with that person. That's what makes that person safe. And that's what allows me to talk about the hard stuff, the shame, the secrets, the fears that I won't be acceptable, etc., etc. All the things that would be valuable for people in therapy groups to be talking about, whether that's in the context, right, of a psychoeducational group or a psychodynamic group. So now how do we work with this process thing, all right, in groups? We just pay attention, as I said, to the how and the why of the interaction. We get out of the way, is the expression. We just leave the group to its own devices. Now, I don't mean destructive devices, but we allow people to speak with each other. We allow the how and the why to just naturally evolve. As a new therapist, fortunately, when I'm anxious, I get quiet. That was the one good thing about being terrified as a group therapist at the beginning. Okay, I didn't talk too much. So the people who, when they're anxious, talk a lot, have more trouble in group because they don't allow the process to evolve. Okay? No, I was too anxious to understand what was happening at the process, but at least I wasn't interfering with it. Okay? So just be still. Just watch how people talk to each other. And only after that's visible to everybody in the group might you make a reflection or a comment about it or ask a question of the group about it. And one of the useful ways to do this, particularly in structured groups, is to use something that we call refractive loops. So if, I've forgotten who my people are now, if Jane's agitation when she talked to Tom, right? You ask her about that and she says something. And then you might go to the group and just ask the group, what was it like to see Jane and Tom sort through the agitation? What was that like to experience that? Okay. So you're asking the group to just reflect back on how an interaction occurred and to give feedback to each other. That's a very scary thing to do, not just in therapy groups, but in life. It requires that we have trust and that we feel safe. So my job as the facilitator is not to keep the group safe by ignoring things. It's to help push them into the hard places and be able to hold that space that allows them to understand that it's safe, that it's going to be okay to be honest and to be authentic with each other. So I've just gotten my 1 minute marker. So let's skip off to the takeaways here. So the takeaways are that cohesion is essential in the transformation of a collection of individuals into a group. That the role of the group leader is to cultivate safety and to promote inter-member communication. In other words, not to be the center stage here, but just to direct traffic. And that the how and the why of the inter-member interactions is more important, or at least as important, as is the content. Because it is the how and the why, all right, that will build connection. And we know that connection in and of itself is healing. Okay. Thank you very much.
Thank you very much, Dr. Mahoney. I think it's easy for all of us to see why you do well in groups. You've taken this complex, for me, rather terrifying area when I first got started and never got very good. And you've given us a framework, and you just look so relaxed as you're doing it. Thank you. We now have 10, maybe 12 minutes for questions, and we have 2 microphones, so we'll alternate if there are people standing at both microphones. Yes, Anne.
Thank you. That was excellent. I have, my question is, when you have a talkative member in the group that's dominating the group, how do you settle that into a balance?
One of the things that I found to be most useful in that complicated and unpleasant circumstance is to hold the topic but move the voice. So I might interrupt somebody and say, "Excuse me, Mary, I know this is really important. I'm wondering how the rest of the group is hearing this." Okay. And so we would refer to that as a horizontal intervention, where you're moving the voice so other people are speaking, but you're not changing the content. It is, in my sense, more of a injury to the individual if I just drop the content and move to another topic, right? So that horizontal intervention generally works really well. And I will be very quick to shut people down, especially at the beginning of the life of a group, if I feel that their level of disclosure is going to isolate them in the room. Does that answer the question?
Over here.
Hi. I was wondering about, from your, that was a great presentation, and from all of your experience, I wondered what is most effective to pay attention to in open groups?
I'm sorry, I would need to know something about the purpose of the group to answer the question.
Oh, that's a good question. That's a good question. Say if the group is to maintain mental wellness, to help group members to prevent relapse of mental illness, of generalized mental health disorders.
Okay, so this is a group of individuals that are functioning fairly well, right? And you want to maintain that level of function. Okay, so, and it's open-ended, meaning it's ongoing. Okay. So in an ongoing group where people's level of function is reasonably okay, it doesn't have to be great, but they're managing in society, I like to give the group lots of space, right? So I often just try to keep the flow of conversation between the two or three or more of them together, going, all right? And I'm always trying to help them deepen it. So I'll always be looking for the underlying affect, right? So if the group is quite comfortable talking about some affects, I'm looking for the ones they're not talking about, right? So I'm just trying to nudge people, right, forward. But really, I'm trying to stay out of the way. And the way I would measure that would be by the we-ness in the room. So the more the group talks about we, so in some open-ended groups, maybe new people would come in, right? Would that be true? Yeah. So when you get a new person in, it's going to pull the group back up into a previous stage. But they'll settle back into the depth of the work rather quickly, right? Okay. If you give them some space to do that.
Great, thank you.
Great, Anne.
Hi, thank you very much for that talk. I'm just wondering, is there a role for self-disclosure on the part of the therapist?
Yes, that's a wonderful question, and it has a very complicated answer. So I'm going to try to give you the maybe, right? So if we talk about a self-disclosure in terms of here and now transparency, all right, there is a stage of development in any therapy group where that would be positive and extremely helpful. Okay? So what do I mean by here and now transparency? So someone has done something in the group and I have an emotional reaction to it. If the group has gotten through the first couple of rounds of cohesion, if they have gotten through at least one round of what's called differentiation, where they can disagree with each other, where there can be arguments, and they can feel safe and they've come out the other end of that, and they're in a working phase, then it might be very helpful for me to say, Mary, I was really surprised and taken aback by what you had to say. I don't have to explain why I feel that way, but it would make sense, all right, to explain it. In part because it's all over my face, and if I don't explain it, they're going to make up a reason, and that's likely to be much more damaging than the truth. What I would never do is I would never make a self-disclosure about my personal life, right, that wasn't absolutely necessary. So I will tell you a story, a personal story. So as some of you know, I do work with therapy involving horses, and I also do therapy involving dogs. And there was a time a couple years ago where I had a dog who was really anxious. And the bottom line is the dog had to come to group with me, otherwise she was going to be in the room above our heads whining the entire 90 minutes. So the group was really good about this. They got really used to having the dog there. And then one day she wasn't there because she'd been killed. She'd been run over by a car on the weekend. So I couldn't not talk about it, right? It was all over my face. You can hear it in my voice right now, right? That there's still an emotional pull there. So I did talk about it, but I talked about it in terms of the impact that it had on the group that she was gone and all right? So I was honest about how I felt and then left it with the group to talk about what was it going to mean that first the dog was dead, but second that I was reacting to the dog being dead, right? So I made it here and now, right? Transparency. Okay.
Yes.
Hi, thank you very much for your talk. I just have a question, and I'm new to pretty much all concepts related to group therapy, so if I sound simple, it's because I am simple. So when you were talking about promoting disclosure in cultivating cohesion and using that honesty and empathy, I just wonder if I'm maybe interested in doing that, but the group hasn't, it's still in the process of cohesion and that safety isn't quite there yet, and I maybe push too much. Is this, finding that balance, is it just a matter of experience? And then if I do find I maybe push too much, how do you get it back?
Okay, this is a really good question. And the thing that's important to know is the group will never let you go any farther than they're willing to go, okay? They will always regulate what the group can tolerate. People will just refuse to answer the question, right? If it feels too threatening to them. And then from my perspective, the useful thing to do is go, that's fine, certainly we'll respect that. That's what you want to model in the group. You're not making them do anything, because that's not going to work, right? But you could ask them, can you tell the group why it's too scary to answer that question? Or what is it about the question or how I've asked it that's too much, right? And then that opens the door for the group to talk about what level of safety are they actually at. And see, no problem. Okay.
Any last questions? In that case, please, yes.
I was wondering if there are any types of groups in which you would not encourage people to talk about their reactions to what other people have said, or well, actually more specifically, that you wouldn't necessarily point out affective responses that people haven't decided to talk more about on their own. So are there certain types of groups where there's a particular topic that you're maybe trying to teach, where you wouldn't do all of these kind of cohesion building maneuvers that you talked about, or would you say that this should apply to all psychotherapy groups?
Well, if we're talking about psychotherapy groups, then I think it is you're better off to apply this in some way to all groups. What would change from between groups would be the timing of when I would speak to an affective interaction, and the language that I would use. Okay, so if it's a 6 to 8 session group that has a lot of content, I'm going to ask about the affect that's being demonstrated in the group in relation to the content, right? If it's an open-ended group, and the person who is being whatever they're being, it looks like they're shamed, and there isn't a lot of safety in the room yet, I might say something like, Mary, it seems like this is difficult for you right now, where when the same piece of behavior happens 2 months later and the safety is much higher, I might say, Mary, you look like you were just shamed. Are you able to talk about that? So I will move this along a continuum based on the purpose of the group and the stage of development. And I didn't talk about stages of development today at all because, well, we'd still be here tomorrow.
What I was wondering about is, I feel like in residency, when I was taught about leading groups where the focus is building a specific set of skills in the patients, I wasn't really encouraged to do the things that you're talking about here. And I guess I'm wondering, are there types of groups that are more skills-based where you don't do that? Or was there something maybe missing from my training, which is certainly possible?
So when you don't do these things, you continue to have a collection of individuals. And there are many places in life where a collection of individuals is good enough. But if you're going to run a group, you must know how to cohese the group, right? And therefore you do need to go where I'm talking about.
Thank you. I'm afraid we have to end this now, even though there may be more questions if we just let them percolate. Dr. Mahoney, as a small token of our appreciation, I'd like to provide you with this gift, a little remembrance of Nova Scotia. And I hope that you have the opportunity to be training and working with our staff in the future.
Thank you very much.
Thanks.